There we go. Thank you. Good afternoon, everyone. This is Spencer Green. Thank you for joining today's presentation. I will be moderating today, and why don't we give about another 60 seconds or so for people to join, and we'll kick this right off. Okay, we're at 12:01, and out of the interest of time, I'd like to jump right into this. I am very pleased to welcome everyone to today's webinar. We will be featuring osseointegration today, which is the third webinar in 2021. COPA continues to advocate for our members and the profession of orthotics and prosthetics in California by bringing forth unique events just like this. You may have heard, but COPA recently refreshed its website. I'd like to draw everyone's attention to the screen. It's californiaonp.com. And what we did in the refresh is to maximize the value and the resources available. So for anything COPA related, anything ONP related in California, check out the COPA website. I will say that members have access to information beyond non-members. If you are not a member and would like to become a member of COPA, click membership, join COPA, and there will be a link for an application. We'd be happy to welcome you into the association. Additionally, under the events tab, we have a calendar of events, but also a list of past events. For instance, today's webinar will be recorded, and you can find it right here under the past event recordings. Now, this is only available to view past events if you are a member. You can see the floating banner here at the top of the page, and as it cycles through, you'll see that we are advertising our fall symposium. This is planned to be in person. Will be held at Pacific Medical in Tracy, California. They have a beautiful facility, and we're thankful they're hosting us. Looking forward to a great event. So mark your calendars, October 14th and 15th. Registration will occur in the June to July timeframe. Okay, so let's go back to our presentation here. And I have the privilege of welcoming Kurt Collier. Kurt is a certified prosthetist as well as the Vice President of Prosthetics at Integrum. He's also adjunct faculty at the University of Maryland, and he brings his knowledge and experience to prosthetists, surgeons, and patients through Integrum. He's lectured around the world on advanced amputee rehab, prosthetic research, and prosthetic products. We're very excited to welcome Kurt today. If anyone has questions during this webinar, please, you can use the feature to raise your hand and we'll look for it. But also feel free to use the chat box, and we'll be monitoring it and can bring the question up at the appropriate time. We'll have about 15 minutes at the end of the webinar to cover questions. So Kurt, the floor is yours.
Thank you, Spencer. Very kind of you. Let me pull up my presentation here. Wonderful. Well, it's certainly an honor and a privilege to be able to share this information with COPA, with our field. You all have actually had the unique opportunity to have been involved as far as the state goes for quite some time in Northern California at University of California, San Francisco under the direction of Dr. O'Donnell. Subsequent to the opening of his program, we have opened up many hospitals across the US, and as we do so, you know, and I interact with the field, one of the things I've identified that I truly believe is important is that we as clinicians, we have an opportunity to become the responsible referring individuals into the various hospital systems. As osseointegration has developed, a lot of it has been developed through social media. And if you look online, you'll see that the patients refer to one another and direct patients where to go. They answer their own questions. And I just think that's the nature of how this osseointegration is developed. in our profession, but I think we have an opportunity and I think we have a duty if we can understand the process, and when people come to us and want to talk about it, then we can be those that educate our patients and potentially refer the patients or let them know that they're not necessarily a candidate. So that's the objective of the presentation, is to help us understand osseointegration, what's going on and about the field itself. So if you have any questions, or please feel free to ask. We'll be happy to answer. So when we take a look at the osseointegration and we take a look at the time and place that this has been in existence, right, we understand that we've always had to deal with a socket for quite some time. And when we're eliminating the socket, right, and we're literally going back to a closed chain system, right? So biomechanically, we're going from an open chain system back to a closed chain system. And I know that we can identify all the issues that are appropriate with the socket, but when we get into the rehab portion of this, this piece with our patients, the rehab part and the discomfort and the challenges that we face are oftentimes a part of just neuromuscularly returning to this closed chain system. So I like to share that on the onset. How did we get to osseointegration? Well, back in the 40s and the 50s, we had two camps of researchers basically doing the same thing in Liverpool, London, and in Philadelphia. What we were doing was they were trying to find an alloy that could be placed in the body and not rejected. So at the time, they found this alloy called Vitalium that could be placed they were placing it in the femurs of rats. And they were identified that over time, they thought it would get the screw that they were placing in the femurs of the rats would get easier to turn, thinking that a biofilm or infection would develop. But what they found with this Vitalium that is now known as titanium actually was absorbed into the bone and accepted into the body. It was a groundbreaking study. Dr. Leventhal at Mount Sinai, he basically upgraded the study by adding a torque wrench. But that study led to P.I. Branimark's investigation with the bone integration in this system. And he began to complete research on rabbits, looking at microcellular blood flow in the femurs of the rabbits. He created a titanium funnel that he could place in the rabbit, and he realized that the bone actually absorbed itself into a spot in the funnel that he could see this. Right? He was mesmerized by this idea, and he kept it at the forefront. So in the late 70s, we actually had an opportunity, an approach to osseointegration for transhumeral patients at Rancho Los Amigos. And Dr. Mooney there attempted to provide these integrated prosthetic devices. The mistake that he made in hindsight was he used bone cement in spongy bone. And that's not accepted and by the body. And it's subsequently been realized. And as a result, all of these failed. So I think a little bit, some of our colleagues in the field that have been around for a while may have been impacted. There is a little bit of a negative tone to this, and I understand having a piece of metal sticking out of your body and loading a prosthesis to it is unaccustomed to us. But I do think there's a little bit of an influence from this earlier failure in our profession. As I mentioned, Dr. Branimark, P.I. Branimark, a researcher, right, was looking at this blood flow in these rabbits, and it left that impression upon him. In a later project, where he was involved in cleft palate research, he remembered this titanium that was accepted into the body. And he was able to utilize that to help bridge that cleft palate. He went on to place this in the skull and in the bones of the head for cosmetic restoration purposes. Eventually, this approach led him to the development of prosthetic dentistry. Right, the whole field of prosthetic dentistry, where you drill a hole in the mandible, you tap the hole in the mandible, you thread an insert into it, and then that insert that's threaded into it has a small hole that you can place a tooth into. Right, the tooth is modular. If the tooth wears down, you can unscrew the tooth, but the implant stays in place. So this entire concept has been around really for quite some time, and the research goes back to the 60s with the development of this. So a fascinating story. If you haven't heard it, if you have, I'm sorry, but I'm going to tell it again. But what was developing at the time with this prosthetic dentistry in Mölndal, Sweden, was this big awareness of this osseointegration. So there was a female patient who was a bilateral transfemoral amputee who's hearing about this in her hometown. She starts writing letters to this company, to PI Brand, Mark Sharon, that she would like to have osseointegration, supersize the dental implants and stick them in my femurs, right? She wrote over 20 letters to influence them to do this. They did the research, they discovered that this was an opportunity for them. At the same time, Dr. Rickard Brandemark, PI's son, is completing his medical school program after a mechanical engineering undergraduate degree. So he takes the lead on this project and becomes the first to osseointegrate this individual, right? Which led to the OPRA implant system. She was our first patient that was provided with osseointegration in 1990. She's still implanted today. So when we take a look at this osseointegration as a field itself, right, we have two different types of implant. Now, when I first got into this, all I heard was osseointegration. I didn't understand the different procedures, but if we understand the different procedures, again, we can help our patients identify which path they want to go. So in these two designs, we have a threaded fit design based on that dental implant application, where we create a hole in the medullary canal of the bone, we tap it, and then we place a fixture in the bone and allow that to be healed into the bone itself, a threaded fit design based on the dental industry. The other design itself of osseointegration is a press fit design, right? So you have blades that are placed in the medullary canal, they're hammered into the medullary canal, right? Until those blades are, which are attached to a collar. And when the collar abuts the end of the bone, right, the blades are in place. So if we think about that design, right, the blades are in the medullary canal, a collar is holding them in place, and the femur is resting on the end of that collar, right, we can complete a load transfer, right, through the cortical layers of the bone into the collar, right into the prosthetic foot. So when you hear the press fit design, we also hear a one-stage surgery is possible. We hear a shorter time to standing and loading. Maybe not a shorter time to osseointegration, but a shorter time to loading. And that's an advantage, right? That's something people don't want to wait around. And I can understand where this has its place in working with our patients. So we have several different manufacturers. Just to highlight the OPL system, the first one we see is Dr. Medeiros' system from Australia. He's provided quite, over 2,000 implants. The Endo-Exo prosthesis is similar design, press fit. That's the second implant designed to the OPRA system. Dr. Aschoff developed that. It's only available in Germany. ITAP, we may recall from our literature reading about the hormones of deer velvet trying to be used or mimicked in growing the skin around the abutment. They all failed and have since been removed. The OTN system is the Dutch system. We hear social media or online, we'll see Dr. Stone back at the University of Colorado providing it. And then we have a compress device with Zimmer Biomet, and that's been discontinued. They provided 7 implants here in the US and then discontinued the program, which is another consideration, right? So there are 7 patients out there that are floating. And the POP system was the system developed by the VA, and we read about their implant used with in conjunction with Utah. They provided 10, they had 7 successes in that initial study. But these implants themselves can be, well, we know the OPL system and the OTN system, they're here in the US, but they're here in the US through a compassionate use pathway, right? So that pathway is a means of the doctor applying to the FDA for this one patient to utilize this implant under the understanding that there's really nothing else available, which at this time isn't necessarily true. OPRA system by Integrum has taken probably 6 to 7 years to work with the FDA to approach them to provide this implant into the United States through the proper channels. Originally, we had what's called a humanitarian device exemption, which is a full FDA approval. It just comes with a little governor. We could only do 4,000 implants a year, right, in the US. We haven't come close to that number. But we wanted to continue on. We wanted a full market approval. So just in December of this year, we received a PMA from the FDA and for the transfemoral level. The other levels you see here are not FDA approved. They're not necessarily available in the US. They have been provided in limited capacity at Walter Reed. But in respect to the FDA, we invested time, resources, and effort to do this so that it is a viable healthcare procedure within hospital systems, within insurance systems. It's been an arduous process, but well worth the time. When we look at in the improvements that this osseointegration, the OPRA system makes in the quality of life and for the patients, there's a wealth of research that has been done, but I'm really excited about the research that will be done. This is all, as you can see, 2014 is probably the most up-to-date research here, but there's a wealth more coming that's already underway. But if we understand very clearly, if we get rid of the sockets, right, we're gonna, all those skin irritations are removed. If we directly anchor something to the bone, the vibrations are unbelievably well distinguishable. Right, so it was reported at the VA study in Utah that a patient actually rejected a knee. Phil Stevens from Hanger shared this with me, that a patient rejected a microprocessor knee because the vibrations from the micromotors opening and closing the valves in the C leg were disturbing. Right, that's fascinating, right? They got him over the hump. They desensitized him to that, but originally that's the amount of perception that one can have. Ease of prosthetic attachment is another, where we think about, and I'll show a nice video in a second, but if we think about a double-walled elevated vacuum socket, right, that could take maybe 3 to 4 to 5 minutes to don. If it's externally rotated 2 to 3 degrees, does the patient take it off? Right? When we're bone anchored and we put the prosthesis on, we put it on the same way every time. So not just is it anchored and easily donned and doffed, but what might be missed is the fact that the prosthesis is always on the same way. So that alignment is practiced. The gait is practiced with that alignment every day, and repetition is going to make so much more of a difference. Upper extremity, for example, they can identify the point placement of the terminal devices is enhanced significantly because there's no slop. Right, we're not having to move the socket through compression of the soft tissue that's compressed by the bone against the socket wall. Right, range of motion makes sense. Right, we're no more limitations in that regard. When we talk about who's eligible, right, who is a candidate for this? Anybody that has a documented socket issue. Actually, with the FDA, and the PMA approval, they just made the announcement that if you perceive the patient to have future socket issues as a result of a short limb or invaginated scar or skin grafts, all of these are means of an approval for using this OPRA implant system or osseointegration for a patient. In the end, the call isn't ours, right? The call is the doctor's. Right, the doctor makes the decision who qualifies for this, right? And I share that, I make that point for 2 reasons. One, when we're looking at who the doctor is reviewing, right? We can refer the patient to the physician, and have them to make an appointment to be evaluated for osseointegration. We can help the physician if we choose to, which I think is wise, right? If we're developing a relationship in this scenario, right? If we're able to help our patients and screen them, right? So if we're able to, if we don't send diabetics who it's not appropriate for, if we don't send individuals with peripheral vascular disease, right? If we don't send individuals that we know will not be competent enough to handle the responsibilities, right, we're helping that physician out. In a presentation where Dr. O'Donnell from UCSF led, he shared that initially, when they first started their program, they had a website and people could find the website and say, I want to be evaluated for osseointegration. In the initial evaluation, 50% of the people were removed because they had diabetes or peripheral vascular disease. With that said, once they got into the pool and they evaluated, another 50% was eliminated, right? So only a quarter of the people were actual candidates. if we help them and remove some of that initial 50%, well, we're providing a service. The other piece is the physician, I shared, the physician makes the decision. So the FDA label, what's published with the FDA is an age rating of 22 to 65 and individuals that are under 220 pounds. With that said, though, the physician can make the choice to go off-label, right? So at Walter Reed, we have a wealth of individuals that are over 220 pounds, right? But the physicians made the choice. The AXA product here is rated to 285 pounds. Right, so it's not a weight rating thing that the weight is based upon. It's actually, it's a shame we sent a Swede to the FDA, and when asked that you don't have a weight rating, what's the weight rating? They thought 100 kilograms would be a good number, and it's a nice round number. They hadn't really spent any time at Kentucky Fried Chicken in America. Nonetheless, it's the decision of the physician to go off-label, right? Botox is off-label for wrinkles. It happens all the time. Nonetheless, we don't have to make the choice. It's on the physician's shoulders. Who's not for? Individuals, as I mentioned, with peripheral vascular disease, individuals who aren't finished growing or pregnant due to the hormones, and we want that balanced. I like to point out in the first where they say it's poorly controlled, implying that if controlled, they would be candidates. And that's possible. I just haven't found many amputees that lost their limb due to PVD or diabetes to get it under control after they lost their limb. But that it is possible. It isn't for individuals for high impact activities. And what we're looking at is really, we want people not to create high moments with an implant in the medullary canal. The forces of running are extremely high, up to 8 times body weight. Jumping is the same thing. So I understand people will want to do this. People will feel better than they ever have. But the challenge that presents itself is, is it healthy for them? And can they refrain from doing so? Maybe down the line when everything is fully osseointegrated, the bone is super healthy, and we know we're not at risk of intermedullary loosening of the fixture itself. Okay, maybe it's an opportunity for that individual, but we do want to start with controlling that message, right? It's not for running, it's not for jumping. You could still certainly be fit, and you could do all kinds of other sports and activities, just not high impact activities. I like to introduce a little bit of the surgery through this animation. It helps us explain the process. So we provide the implant in a 2-stage process. In the first stage process, we're going to place the fixture in the medullary canal and then basically close the limb. At this stage in the patient's care, right, they're here on the table providing the surgery. So they've already had a 0.6 millimeter MRI done of their bone to identify the cortical bone thickness, right? We need 2 millimeters of cortical bone for them to be a candidate. Right, so we also use that MRI and a CT scan to identify the diameter of the fixture. The fixture is round, it's placed in the medullary canal. So we want to understand what's the opportunity, the best diameter to use. So Dr. Brandemark himself makes that determination based on these films. Then we send a kit, right, to the hospital prior to the surgery that has these hand auger drill bits specific to the size of what we're going to place. We do all our augering, we do all our drilling by hand. An electric drill increases the heat in the bone and is not healthy. We're going to come back once we get the diameter open to the specified size, and we're going to come back and tap the intermedullary canal. By tapping this and we place a threaded fit implant, we actually increase the amount of bone to implant surface contact as opposed to a straight implant itself. So we have a wealth of load-bearing capability already at this stage when we place the fixture in there because it's tapped in place. The fixture is also laser etched, so it does grip itself inside the bone. Right, so here we can see we're very carefully placing this implant, and we place the implant recessed, right? We place it deep in the medullary canal. So there's a bunch of handling techniques that are used with the implant before it's placed in the medullary canal. And then we come back and we thread it into place carefully into the bone. Once it's put in place, We then place some marrow in the proximal to the bone itself. But then we also have this central screw. I'll stop right here and share this central screw. I mentioned earlier when Dr. Brandemark was receiving his undergraduate degree, he was a mechanical engineer. So he's made this entire system modular by design, right? So this central screw has several different functions. That central screw allows us to look beyond the fixture if needed, if there's an idea of an infection. It allows us to have access as well as if we want to utilize that space to probably maybe run some wires. It also has a strategy for an exit strategy if we need to remove the fixture in the worst case scenario, if there happens to create a bone infection. Right, so after we place that fixture in place, we come back and we place a healing cylinder in the bone. And this is the crucial part that if we can grasp, we understand what our objectives are once we start to take care of the patient during the loading phase. So this healing cylinder, as you can see, has a smaller diameter, right? And that's the diameter of the walls of the abutment. So what we're really doing in between stage 1 and stage 2, right, a 2-stage process, is we're downsizing the medullary canal at the distal 100 centimeters of the bone, because we want that to support the abutment instead of having the wobble, right? And so the actual reason for this healing period is to allow that distal aspect of the bone we'll take the shavings, right, and pack it in there around that cylinder, and then we'll place the cap in place that's a little spring loaded and creates a little bit of a load, so Wolff's law. That will allow that distal portion of packed bone, shaved bone, to mineralize and harden, right? And we can run a CT scan to identify the extent of that, right? And then we can move forward with the rest of the procedure, right? So when we get after a 3-month period of time or 6-month period of time, depending on which program the doctor has decided to use, we'll then move into stage 2 process for the surgery. So again, we're on the table, right? We can take a look what we're doing. We open up the residual limb, then we remove the hardware, right? That's in place. And then the plastic surgeons step in, right? So there's usually a team of an orthopedic surgeon and as well as a plastic surgeon. Or sometimes it's a hand surgeon, but usually a plastic. What we'll do is we'll guillotine all the muscles of the femur, 1 centimeter proximal to the distal end of the bone, and then we carefully suture them to the periosteum, creating a pseudomyodesis, right? So we're realigning all the muscles in their true angle of pull, and then we're anchoring them to the bone itself. Now at this stage, what we'll do is we thin the skin, the surgeons, I don't, but they'll thin the skin and remove all adipose tissue, all the way down to the hair follicles almost. And what they're going to do with this posterior flap is we'll take that posterior flap, we'll close it and suture it anterior in most cases. And what we've done here is we've created a scenario where we're capitalizing on the bones and the tissue, the dermis's ability to create adherent scar tissue. So ironically, something that we've not liked and didn't want with our patients enables these individuals to have an anchored skin exit site. So to the point, right, when we're able to create this anchored skin to the end of the bone, we stabilize that tissue. When we provide this in a 2-stage process with a period in between, we're allowing the bone to heal itself. And then we're creating the ability to keep the end of the femur accessible, right? Remember the press fit design? The press fit design, the collar covers the end of the bone. Here, we're actually allowing the bone to heal itself, right? To the bone itself, the vascularization grows out of the distal end of the femur and takes care and provides the nutrients to the skin in that area. That's why we'll move so slow in the initial rehab setting after the 2nd stage surgery, after the surgery, because what we're trying to do is allow the dermis to adhere itself to the end of the femur, as well as allowing this muscle platform that we created to scar and gel in place, right? We're not gonna have strong contractions for a period of time because we don't want those muscles to pull themselves off the periosteum. right? So as a result, press fit versus threaded fit. I share the press fit design because we can load through the cortical walls to the collar to the prosthesis. We can load bear earlier in a rehab setting, right? But if we take a little bit more time in the scenario, we have an opportunity to allow the dermis to heal itself to the end of the femur, creating an opportunity to stabilize the skin, to provide nutrients to this exit site and have a much healthier abutment exit site, as opposed to an open stoma that is there for the rest of the individual's life. When we look at this two-stage process as well, this is a busy slide, but what we created is an opportunity to develop a modular system, right? So if we have a modular system, if we have wear and tear on the abutment, which will happen, right? We're going to take the axer in and out of the abutment in and out of the axer a lot, all the time. So over time, we will have some wear and tear, and the abutment may need to be changed. The abutment could become bent if somebody provided excessive loads on the system. Well, we can replace the abutment. I will aside, we've provided, since we brought to the United States the OPRA system, we actually introduced the G platform, which is 60% stronger than anything that was provided prior to the introduction of the OPRA system to the United States. But also what we're able to do if we create a modular system, right? Not only can we repair components if we need to and replace components, but we create an opportunity for the individual to be upgraded with future technology that's provided as we grow forward in society, right? We don't want to lock somebody into time. So I mentioned that central screw. That central screw can be removed. And what if we were able to pull wires that came through that were a part of the abutment, an updated abutment that's like a plug, right? Run the wires through the abutment, pull them through the central screw hole in the proximal aspect of the fixture, drill a hole in the bone, and then directly place the leads into the muscles themselves. We no longer have to use surface EMG, right? We no longer have to worry about our control systems having crossover signals, right? So here we see one of our 5 patients that have this OPRA system, right? And you can see with the COAP system, state-of-the-art, right? And it's still an osseointegrated system. He has a hard time managing through crossover signals. Direct wiring, right into the system, right? We have so much enhanced control, so much refined motor skills for small micro movements, as well as there won't be any crossover signals coming from the shoulder, right, into our EMG surface electrodes. So our control capability is far more enhanced with OPRA. We're also working currently, there's DARPA proposals and the work going on with MIT, right, to bring this to the transfemoral amputee population as well, right? So it's not available, it's not commercially available in the US, but to the point, the OPRA system is modular, not only for repair, but it provides an opportunity to enhance a person's utilization, their skill set with introduced new technology. OPRA itself, one of the things that we pride ourselves on, and what's going on right here, is we provide a wealth of training, right? We want this continuum of care, right? When we were able to align ourselves with the physician in the ideals of having the best outcomes, and we can work with the physicians, we can work with the PM&R doc, we can work with the physical therapist, we can maybe work with the nutritionist, which has been brought into some of our centers as well. And we work with the prosthetists, and all of us understand the OPRA system, right? Then we have a continuum of care. And it's fascinating, right? Because we all do have to work together. And as I mentioned, the surgeons may only have 5 or 10 of these patients. They know who they are, right? So if you need to communicate something's up, you have pretty good access. So it even fosters this continuum of care as well. And it's the model of the company, right? So as we continue to grow this and open up centers across the United States, we provide introductory training to the therapists, to the prosthetists. We provide certification training to the prosthetists, to the physicians as well. I've also taken the time to work with ABC, our governing body, to help assure the fact that working with an osseointegrated patient is a part of our canon of ethics, right? So this is a part of what we do. And this is actually stated in our canon of ethics that as long as we're working with the abutment, the components that attach to the abutment, right? The AXA or the connection device, and caring for the patient and following the manufacturer's IFUs, we're set, we're fine. I mentioned prior that it's a two-stage surgery process and that we have registered with the FDA. And so you can see the rehab protocol here identified. Over 90% of our surgeries done in the United States right now are done with this 3-month time period between stage 1 and stage 2. I mentioned this is an off-label determination by the physician, right? So as such, when I present material, right, I have to present what's registered as part of the product label with the FDA. So this is what you'll see. And this is possibly what some of our patients will see. It's out there, right, on social media. So when they have the questions, you know, we could certainly share with them that that's not always the case. In most time, it's not the case at all. So once we complete the stage 2 surgery, we then have the opportunity to move into the rehab portion, right? So we may or may not be engaged a whole lot in between stage 1 and stage 2. There is an opportunity, and some prosthetists have felt it appropriate to fit a socket in between stage 1 and stage 2. It's hard to do with insurance. I understand. It's also hard to do and with a time period, right? But it is, if we don't want somebody to decondition, there is justification. Can they use their old socket? It's possible. The key component is we don't want to load the distal end, right? Because we had hardware in there. We had that sealing cylinder, right? The cap. We don't want to do any damage to that. So we want to make sure that we're not loading that. Maybe we can adapt a socket with some foam up to that distal pad if room can be made. I mentioned we're going to utilize this abbreviated process as well, and I've highlighted that a couple times. After the stage 2 surgery, right, we're going to see the patient is going to be wrapped and treated as we see here in the bottom picture. You'll also find that the white component that's attached to the end of the limb is called the puck, right? So this is attached to the abutment. At this stage, what we're doing is providing some pressure, right, to allow the skin to start to adhere to the distal end. We're also providing some protection to the limb as well. Dressing changes will take place 2 times a week typically, and that puck will always be placed put in place in that regard. Just a tip, I have seen some prosthetists when the patients are here at this stage, they're typically at an inpatient rehab setting following the 2nd stage surgery. The prosthetist will make a visit and they'll provide them a shrinker, but it's a pseudo shrinker. It doesn't have any compression to it, right? It's just it's like a sock that they can use to help all the bandages that you see stay in place and not get pulled down by the sheets. But it's also a nice means of starting some communication, starting the process as well. And the images on the right, you can see the actual dermis on the bottom right has adhered to the femur, and you're starting to see a skin flap fall over the adhered tissue to the dermis on the proximal aspect of that abutment. So as I mentioned, after the 2nd stage surgery, we begin to move into the rehab aspect of our patient's care. This is where we get involved, right? I have more courses that I provide much more in depth, but to help us understand what's going on and what our involvement is, what we share is the rehab protocol that was developed by Kirsten Hagberg. She provided this rehab protocol and working very closely with Dr. Brandemark to provide a means of loading the limb and very carefully introducing the patient to, as I mentioned prior, a closed chain system. Making sure that if we move forward slowly but with purpose, we'll get the outcomes that we want. Prior to the implementation of a structured rehab, there was a higher rate of failures, right? We need to go slow. We need to communicate to the patients that this rehab process will take time, right? It's our expectation. So here you see the rehab protocol. It's basically broken down into 4 settings. Walter Reed took the program that you see here, right? And then they made subsets, right? So there's 8 different stages. When it comes time, you have a patient, what will occur is I'll get engaged with the PMNR doc or the physical therapist, and I'll help walk them through some of the training that has been developed and outlined with some of the do's and the don'ts. I'm not a physical therapist. This is material that's been provided to me that I share at the time. But you can see we have primarily 4 stages of rehab. The first stage of rehab is going to involve a loading, a short limb loading connector. The short limb loading connector is purchased through Ottobock, and the idea is what we're going to do is create a system in which we axially load the limb through the fixture, right? So we know the natural hanging angle of the femur in the frontal plane has an adduction angle, right? But in this stage of rehab, what we're looking to do is create a loading pylon that is knee length, right? As you can see here, that is going to allow him to truly axial load the pylon directly through a vertical abutment. So when we're aligning this system for a shorter limb, we want to share abduct your limb, sir, because we want this vertical pylon. Your guide is the abutment, right, at this stage. The physical therapist will be trained on this. We simply make the device. They utilize this device in their rehab. They'll start with a loading of 45 pounds. They'll increase this 20 pounds a week. They'll start up 15, 20 minutes twice a day with a pain threshold to 4, right? We don't want them to overdo it. Again, we're returning to this open chain, to a closed chain system. There's been a lot of work gone on the bone. So slow and sure, right? We don't want individuals to push, grin and bear it, right? We don't want you to have to deal with all of this pain. The other piece is here, you have people that are very anxious about the process, right? And they're concerned. So we don't want to have people confused by delayed onset muscle soreness. Finally, we're going to get to our full length prosthesis, right? We're at week 10. Right? So this is a period of time. We've already taken some time through the loading process, right? So we're just starting to use our prosthesis. We're going to incorporate the axer itself. The axer itself is going to provide us a means of donning and doffing, right? By very quickly doing so, right? And attaching the system. It provides safety, not only security for donning and doffing, but safety in the frontal and the coronal plane. If we have a high torque force, the system will rotate at 15 Newton meters. You can put it back in place, right? It's just released, nothing's damaged, but it provided the safety for a high torque force. Somebody falls to their knee, right? At a fall to their knee, it'll release in a hyperflexion moment at 75 Newton meters, right? After they catch the breath, I'm sure they'll be overwhelmed by a fall. They can replace the system back at 35 Newton meters like a ski binding, right? And catch the breath, and they're able to ambulate again on the system after it's released. It doesn't need to be repaired, right? You'll probably get a phone call, understandably. Somebody may want to see you. That makes sense, but the system is designed to be resettable, right? So here we can see the means of donning and doffing very easily, right? 20 seconds or less. Eric Axe here has done it many times, right? We're going to take it, tighten it just like a drill bit, right? Tighten it. He's going to wiggle it, right? Pull it and tap it just to make sure everything is seated, right? Just good habits to create. Prosthetically, when we're looking at the system, right? And there's more information I could share in a more in depth, but just so we're aware, in the sagittal plane, we don't want to use an offset adapter, right? We want a true axial load, especially for the first 2 years. Right? So what we're trying to accomplish is, again, in the sagittal plane. Frontal plane, yep, let's return that natural hanging angle. Let's start working on that rehab, but from that natural position. But in respect to the use of an offset adapter, right, that's going to create 2 loads, right? That could create a moment in the implant in the bone itself. What knees can we use? Any knee can be used, right? I've seen them all out there. But a microprocessor knee is going to be able to provide us with the resistance and swing phase at heel rise and at terminal extension to provide us the dynamics where we need that resistance. Remember, we're not compressing tissue against a socket wall to get the knee to move or the components to move. The moment the femur moves, what the components are going to do and react, they're required at that point in time. Power knees are not to be used. We just don't have any science. Conservative company, right? So no powered knees and no powered feet. But keep in mind, the moments are much higher and quicker. So we always want to make sure we're looking at our warranties on these products as well. The durability is going to be challenged. So we want to make sure we have products with good sound warranties. I will stop here and share that in Kirsten Hagberg's presentation and her material and her published study, she states that microprocessor knees aren't to be used until 6 months out. I've communicated with her and talked to her. That original was based on the fact that it required a specific toe load to release a knee in the swing phase. Working for the manufacturers and other roles in my career, I know we've found ways to reduce the need for a specific toe load because we had too many shufflers. From a standpoint of the manufacturer's perspective, if we didn't require that specific high toe load to release in a swing, we could sell more knees. So that requirement has been eliminated for most of the products, most of the microprocessor knees. So that opens up that protocol to start with the microprocessor knee once we move to this stage. What feet should we use? We want to use a good carbon fiber foot. We want to keep something that's very flexible. Ideally, if we use an anthropometric foot, right, we're going to be able to reduce the moments through mid-stance. That's a long lever, right, working on an implant in a short femur, right? So if we're able to remove those moments through mid-stance, we're creating a healthier system. There was research that was just published on transtibial implants and anthropometric feet, talking about the moments being reduced, and it would be healthier as well. So that's starting to be developed and identified in the marketplace. Again, the powered foot is not appropriate. In gait, we take a natural stride length, right? So we're looking for a system that enables us to have some rotation, right? We get we get about 5 degrees of rotation between the knee joint and the talocrural joint and the ankle. In a socketed prosthesis, we can get rotation on the skin. In a bone lock system, that's not going to happen. The patient will develop a shorter stride length if it's not provided to them. But after the investment of 1.5 years or a year and maybe $100,000, we want them to have a natural stride length, right? So we can provide this component as well. And as I shared, it's going to help with torque forces in the bone itself. Second stage of rehab, right? Now we're in the third stage of rehab, we're about 12 months out. We're going to move from loading the limb and sitting to more dynamic capabilities with the prosthesis, right? We're learning some balance and agility skills. And in the fourth stage of rehab, now we're going to start to really advance and start to work ourselves, become much stronger. We can swim with the osseointegrated prosthesis, not with the AXER. Right, so the individuals are using that short limb connector to create a swim prosthesis as well. So with that said, I want to leave time for Q&A. I'd like to share that what we've talked about today really has been, a refined surgical technique that may take a little longer, but does have purpose. Right, it creates an ability to create a modular system that could be that potential to be upgradable. We will provide more training. So when a patient is provided, when you have a patient that works with one of the physicians in the area, that you have 3 opportunities to refer patients to at UCSF, at Kaiser in San Francisco, as well as Dr. Menendez at USC at Keck Medical. I will provide a document to COPA that you could look on the webpage and find where the pathways to referrals will exist, but you can find the pathway to these regional centers. As I shared, we train these individuals at each regional center, not just the physician, not just the PTs and the PM&R, but also the office staff. Right? We want these individuals that are first contacted by the patients that we refer to have somebody knowledgeable to not answer osseo what. Right? We want them to understand and have a couple questions or be able to answer a couple questions and then move that patient comfortably into being evaluated for a program. Provide training and certification, and we offer this structured rehabilitation. I know it's a lot of material. It's exciting material and it is new for us, but I did want to take the chance to introduce it to you. There are other courses that we provide once you have a patient, but at this time, I'll open it up to questions if anybody has any.
Hey, Kurt.
Thanks, Kurt.
Thank
Go
you.
ahead.
Hey, this is Mark Muller. Thanks, Kurt. It was a great presentation.
Thanks, Mark. See ya.
Just a super quick question for you. I know we've talked about this in the past. What do you think about the level of responsibility that practitioners are taking on the gait training aspect of it? I mean, before, when we have just a traditional socket, we have the ability of the socket to adhere shear forces and cushioning forces within it, and gait could be a little bit off. And what we're seeing definitely on lots of different levels, especially the transtibial level on the non-FDA side, is the gait training and alignment is critical to these abutments. What are you thinking about for training and different certifications for gait and alignment for these devices?
Well, I mean, I think as a clinician, right, I mentioned we're at the initial stages, we don't want to try to shy away from an offset adapter, right, just for the health of the bone. But from there, we're really trying to optimize the performance of the individual, right? So I do think there's going to be, as a clinician, we're going to be engaged consistently with these patients because their skill set will continue to improve over time, right? So we're going to want to be able to make all these alignments, and that's, again, with this continuum of care, we can be in there with those therapists that are providing this care. A lot of the programs are identifying that the rehab portion is a good means for the business to be successful, right? So the authorization for this rehab is really been a positive thing, and patients have been able to get extensive PT time. Right. So as part of this continuity of care, we want to work with those therapists. I do think when we look at this, the whole field of osseointegration, right, we're removing the socket, right? So we're taking a skill set away that we have. So we really want to do exactly what you're sharing. We want to become the masters. We want to be the very end all be all of gait and alignment. And we want to document it. We want to demonstrate it, not just for payers, but just for our own sake, so that we have this body of outcome measures that we continue to develop and move this further into the field itself. That's a good question, Mark.
And when do you think the upper extremity finger ones are going to be going through FDA?
The upper extremity fingers, right? It's available, right? We could do compassionate use. It's a matter of developing the physician, developing the hospital, developing the whole pathway. So it's there, right? It's just it's a busy company, and get the attention to something that is not the focus of the company, but that opportunity it's there if we have somebody that can drive it.
All right, thanks.
Kurt, along the lines of alignments, with transfemoral amputees, it's not uncommon to have a hip flexion contracture. Is hip flexion range of motion part of the that kind of rehab process, and does the myodesis in any way impact that?
That's a great question. So, initial part of the initial evaluation, it's in the product label itself. A hip flexion contracture beyond 14 degrees with a hard stop, right, where it's bone locked, is a contraindication for the individual. If as Dr. Brandemark refers to it, is if it has a soft stop, in other words, tightness of muscle, right, in the second stage surgery, they can provide some release there, right, for those individuals. Also, when we look at the rehab portion of this, with the short limb connector also is one of the best tools that therapists have had, right? So if we're trying to address a hip flexion contracture with a short limb, and we're trying to stretch that limb itself into extension, and through the soft tissue, we can't access the bone because the tissue is rolling around the bone itself. But if we have an actual direct connection to the bone, and we can have the best lever we've ever had, a lot of work can be done on the early stages of rehab to address a hip flexion contracture. In the end, if if we all work with ideals, right? But we know we're going to have somebody present themselves still with a hip flexion contracture, and we have them as a patient, right? So did somebody just spend, all that time, all that effort to walk bent over because we don't address it? I don't think that's fair. What we want to do is be as conservative as we can. Maybe we meet in the middle, right? To not create as much of an offset as we typically would, but still allow that individual to be as upright as possible without putting them at risk. Right, so there is some gray there. I understand it, but we really want to try to address that in the surgery, which is possible and done, as well as with the rehab therapist. But in the end, we know we'll get them, and it's occurred. Thanks, Spencer. Good
Sure.
question.
Yeah. I have another question from the chat box here. What are the potential advantages and disadvantages to doing the press fit versus threaded fit surgical technique for the patient and/or surgeon?
Well, I mean, in the press fit, it's could be done in a one stage and it could be done quicker, right? Meaning that it's single stage and they can load earlier in rehab. The big challenge and the image that I shared was where does the skin go? What does the skin do, right? Is it going to heal itself? I mean, that's not an uncommon image of a press fit skin exit site or stoma. So the advantage for the threaded fit design that sits recessed is we heal the skin to the end of the limb, right? We really can promote a very healthy exit site. We create a system that's modular, that is upgradable for a patient to utilize, right? So as more technology comes down the line, they're not locked where they were when they had the surgery and what's available. As the abutment wears, we can replace it. Right, so we have the modularity for repairs as well. And from there, we just, I think those are the primary differences between the two.
Well, I want to thank everyone for attending today. I also want to thank Kurt for your excellent presentation. Lots of great information that says as clinicians, as providers, should be aware of to make sure that that patients are provided with the full spectrum of opportunity. Please visit the COPA website to get access to this presentation as well as others. And for those members out there, thank you for your continued support. We look forward to continuing our progress through 2021. And a quick plug for our next webinar, which will be based on government affairs in California. It'll be hosted by COPA's longtime lobbyist, Bryce Doherty, who will give us an overview of O&P and Sacramento. Thanks, everyone. Have a great rest of your day. Bye-bye.
Thank you all.
Thanks.